Hello, I want to welcome you to Emergency Medications Every Dentist Should Know. During this series of 4 parts, we're going to be talking about medications that you should have in your drug emergency kit and that you should be ultra familiar with as far as when to use them and how to use them, how to dose them and such. As with anything, we have a disclaimer that says that I am not the ultimate source of your knowledge for this. I've been practicing anesthesia for graduated school in 1994, so this is 2023. I'm in my 29th year, and there's other ways to do things that are just as safe as the way that I do them, the way that I was trained. And I refer you to those lectures, textbooks, journals, and such. I am Alan Schwartz, DDS, CRNA. I've broken the lecture down into 4 parts. Part 1, we're going to talk about today oxygen, albuterol, and inhaled spirits of ammonia. Part 2 is going to be talking about atropine, ephedrine, and epinephrine. Then we're going to be talking about aspirin, nitroglycerin, and sugar glucose. The 4th part will be talking about diphenhydramine, Salucortef, and diazepam midazolam. You're going to be hearing a lot of these drugs repeated in a lot of the different lectures that you're going to be taking with this course as you go throughout all the different course modules. It's things that I absolutely want you to know cold so that you're comfortable with it, so that you kind of maybe roll your eyes and say, I already know this. And when you roll your eyes, or if you happen to open your eyes brightly, I want you to just be knowing that you are solid on those drugs. So just bear with me as we're repeating a lot of important things. So let's talk about part 1, oxygen, albuterol, and inhaled spirits of ammonia. As far as our learning objectives for all 4 parts, we're going to be talking through each of the different parts, the routes of drug administration, why you should stock these certain medications, and then learn the emergency responses to use those medications. We're going to list some common medications, and you will find this in the Drug Toolbox for Sedation Dentistry lecture, how to build your kit, along with the handouts that you'll receive for the course, your quick and dirty drug cheat sheet, and your emergency algorithm sheet will help you build on the knowledge that you're gaining from these lectures. I want you to then learn when to use these medications, their physiology of why we're using them and how to use them, the route that we're going to be administering the drug, and that sometimes there's several, but there's usually one quick main route. And then we're going to slowly build and develop a quick and dirty cheat sheet for your dental office emergency area. Something you can keep in your emergency card so that you can refer to it quickly if there's an emergent or an urgent situation and it might be a little bit hard for everybody to think. And then lastly, there's a reminder to check on the expiration dates for your emergency meds, and that should be true for all of the meds that you're using for patients. Dental boards always look at the expiration dates and make sure that you're not carrying anything that's expired. So keep up on that. It's something that I would do if I were you manually, rather than having to hire a company, which is quite expensive, to send you updated meds and this sort of thing. That's something that you could do in-house and use one of the anesthesia drug suppliers to buy your supplies for your emergency drugs. So with this part 1, we're going to be talking about the importance of oxygen and why it should be the first emergency med that you're thinking of for a patient. And then its modes of delivery. We're going to talk about FiO2. We're going to review the adrenergic receptors, the basic ones, the use of albuterol. We're going to talk about the common routes of administration. I'm going to put them all before you so you can see how meds can be delivered to a patient. And then lastly, we'll talk about inhaled spirits of ammonia. So what we want to do is, again, refresh your memory and make you familiar and comfortable with these drugs. They should be something that you're just totally familiar with. Even if you've never really ever used them before, I want you to be able to use those in the urgencies that usually occur in the dental office. And even though it's rare, the emergent medical conditions that can occur in your office. Hopefully, you're going to have selected your patients and you're not going to have those emergencies and very few urgencies, although they do happen. So we're trying to prevent those medical urgencies from happening. And usually that involves making sure that you take a thorough medical history, screen your patients, and make sure that they're healthy and ready to rock that day except for their needed dental treatment. All the emergencies and anything that we do is based on the CABDs: circulation, airway, breathing, and early defibrillation. Refer back to your notes by doing drills in the office, using your notes, using your emergency algorithms for medical emergencies, and your quick and dirty drug dosage kit, the handout that you'll be getting from us. So make sure that you schedule those on a frequent basis for everybody to practice. And make sure you document then who is taking the course, what you went through. These are drills that you could do every 3 or 6 months. I would recommend at least every 6 months, if not sooner, that you do this with your entire team at least twice a year. Remember that we are obligated to provide the best of care for our patients. And remember that a medical emergency doesn't have to just be a patient in the chair. It could be a relative or a friend out in the reception area, when you go shopping, at a grocery store, at a sporting event, an athletic event. Things happen with people, and it's nice that you know these algorithms to be able to help if need be in an urgent or an emergent situation out in the public. Remember this, that the absolute definitive rules aren't what I prescribe or call them. It's from your state dental board's rules and regulations. If you haven't already, you should download their document. Usually it's in a PDF format, and that is the rules that you need to practice for your particular state or locale, wherever you're practicing. They're the ones that prescribe the things that you need and how you should be able to respond for anything involving the practice of dentistry. So let's now talk about the routes of administration. And we're going to see these as we go through each of the emergent drugs, the drugs that you should know as a dentist. So the first of these is going to be the enteral route. So there's the enteral, which involves using the gut, the stomach, the intestines, and the absorption of the drug through the gut. This can be also through the oral mucosa. The first of the enteral route is just swallowing a pill or oral. Then there's the rectal route. You might be thinking, I'm not going to really use that so much in dentistry. I don't want any part of that. But if you've got someone that has just intractable vomiting, then we would give a medication. It's usually a suppository through the rectum, and that should stop the nausea and the vomiting. And the name of the med that you could give rectally for nausea is prochlorperazine or promethazine. It's given rectal, it's potent in stopping nausea and vomiting. Sublingual is also an enteral route, and it's going to be a parenteral route where we don't involve the GI tract. Let's talk now about the parenteral route. This is the route that bypasses the gut, and it's going to have one similar route that is considered both enteral and parenteral, and that route is sublingual. Drugs can be given through injection or with a pill swallowed and placed and allowed to dissolve underneath the tongue. An example would be nitroglycerin. It's so quickly absorbed that it is considered both enteral and parenteral. It really gets into the bloodstream through the arteries and is carried throughout the whole body. It's really absorbed quickly, and it's designed that way to do that. Another parenteral route is the intranasal route. We can give intranasal Versed. We could use Covinase, which is a local anesthetic. Could also give intranasal ketamine, can be vaporized or atomized and given and absorbed through the nose. Another parenteral route is subcutaneous, where we just slip underneath the skin and we give medication right there. In this case, in this picture, you're seeing a little bolus of lidocaine that will help with the stick of the intravenous catheter. But some meds like insulin and certain other meds are given subdermal or subcutaneous to allow them to be slowly absorbed away from the site of the injection. Another route that's parenteral is intramuscular. The picture of the deltoid, which is the shape of the muscle, and that's why it's called the delta, which is a triangle, or the deltoid, is very rapidly uptaken. So it's almost considered an IV route if the med can be given that way. It's a nice route to quickly get it in line. Another place to do this is the vastus lateralis muscle. And this is something that you could look up in a nursing text or a medical text, anesthesia text, to see where to place that. Another parenteral route, the one that we usually think about, is intravenous. An emergent route that has saved a lot of lives is the intraosseous route. It can be placed into any long bone, and what can be done is to place it either with a drill type device, or as you can see in the middle picture, there's a knob that the person would grab a hold of with their hand, and you just alcohol off the area of the skin and shove it through the outer surface of the bone, and it goes into the intramedullary space. Pull out the black knob. It's then got a hookup that you can see in the person where you see their leg and their pant leg is raised. And it is given and dosed just like an IV. It's used in extremely emergent situations, the battlefield. It could be a pediatric patient or an adult patient in the emergency room where we've got to get fluid, blood, or certain meds into the patient, or they're going to die. Sometimes the parenteral intraosseous doesn't flow real well, so what we have to do is take and use one of those pressure bags that you see, and you surround the IV bag with it, and then pump it up so that it then forces the liquid intraosseously. And again, as I said, intraosseous is dosed the same way that intravenous is. Another route that is becoming extremely important and is being used a lot is the transdermal route. And I really want to go through this with you. You see that fentanyl can be given as a patch, and it's got different doses where it releases a certain number of micrograms per hour. On TV, you've seen commercials probably for Salonpas, which is a 4% lidocaine. You stick that on your lower back and it will numb and anesthetize the area. Of course, for years now, we've had Emla cream, which is also lidocaine, 2.5%. So it's pretty high in concentration. One of the mnemonics to be able to remember that is 2.5%. If you run the decimal point 1 to the right, it's the same as 25 milligrams per milliliter. And it also contains prilocaine, 2.5%. So you're getting a pretty good whopping dose of transdermal Emla cream. Emla stands for eutectic mixture of local anesthetic. And then there's the Nicoderm patch that you see in your picture here. What's been invented is that there are now microneedles that pierce gently the surface of the skin without really hurting. And there's 4 different types of microneedles. You can see there's a solid one. They could be coated with drug or certain medications that stimulate blood growth. There's so many things now. It can be a dissolving microneedle. You can give vaccinations and things this way, or with a hollow microneedle containing medication. Just to show you the difference in size between these microneedles and just a regular needle you can see on magnification. This is a nurse that I used to work with. Her name is Roselle, and she's got constant blood glucose measuring. The device is a microneedle. It measures her blood glucose and displays that, in this case, in an app on her iPhone. They also are coming up with ways to use microneedles for flu vaccines, COVID vaccine, and then coated with a substance that stimulates blood growth. So if someone's got a tissue graft, you could put the patch on with microneedles, and it's going to stimulate blood vessel growth into the tissue so that it survives. Another parenteral route is pulmonary, where we go straight into the lungs and dissolved into and become part of the bloodstream and distributed through the body. And we're all familiar with nitrous oxide, especially in dentistry. We also use that principle in general anesthesia. One of the common potent inhaled agents we use is sevoflurane, and it comes in a special vaporizer because each of the different agents we use, those potent inhaled agents that are inhaled into the lungs, each evaporate at a different time. So we've got to have a vaporizer that is calibrated to allow for that amount of evaporation so we know what percentage dose we're giving the patient. And here we are in the operating room. You can see that we've got the vaporizer on the right. If you look real closely, it's set at about 3.5%. So the person's only breathing 3.5% of this potent inhaled agent. They're breathing some medical air. You can see the little copper bobbins floating there. A liter of medical air and a liter of oxygen, 1 liter per minute. So 96.5% of the gas that they're breathing is the medical air and the oxygen. So this is a potent inhaled agent. Here it is attached to the anesthesia machine on the left, and the patient on the left side, beyond the area of the picture, is breathing with a ventilator and is asleep having surgery, major surgery. As we talked about in the introduction, there's proprietary emergency kits that you can buy. You subscribe to them. I think they're quite expensive. It carries the same drugs that you can buy from an anesthesia drug supplier. So in the medication, they also sell equipment and some anesthesia supplies besides just your meds. So there's proprietary, and you can create your own custom anesthesia cart. This is a cart that I used at a large dental practice. You can see that in the top. In the middle, I've got propofol. Over on the right, I've got my cardiovascular meds. I've got various other meds like anticholinergics on the left, and I got some steroids and antiemetic agents in the lower right. Then I've got my airway equipment and supplies. In the bottom left, you can see my syringes, my microbore tubing so that I can pump drug into the patient's IV, drugs like propofol. And then we've got IV kits, IV fluids, and those sorts of things. We've got larger syringes there too. There's a 20 ml syringe there. I would encourage you to create your own kit. Not only are you going to save a lot of money, but if you pool with other people, you can buy a lot and then split the lot between some of your other sedation dentists in the community, however you want to do it, because you're probably not going to use a lot of these drugs, especially the emergency drugs. But as we said before in the introduction, and you'll hear in other lectures in this course, is that you've got to keep everything up to date. So let's now talk about the 3 drugs that we introduced you to for this part 1 lecture: oxygen, albuterol, and inhaled spirits of ammonia. And you're going to be surprised to hear about, especially inhaled spirits of pneumonia as being an emergent drug. So let's talk a lot about oxygen. We've got different ways that we can deliver it, and we want to get that. That's our first drug that we should think of in an emergency to keep the patient breathing and oxygenated. Oxygen is going to be used to create ATP, which is the fuel for the cells, the fuels that the cell needs as their gasoline. And it's produced in the mitochondria through oxidative phosphorylation. And here is the chemical structures in that. Here's the Krebs cycle, and you can see oxygen is a part of it, and that ATP, adenosine triphosphate, is produced. And notice that at the very top of this diagram, that CO2 is also produced. And we're going to use that to help monitor the patient with end-tidal CO2. Here's another picture again of oxidative phosphorylation. You can see where the mitochondria use that, and it's used to produce, along with glucose, ATP. Again, here's the chemical reaction to produce ATP in oxidative phosphorylation. So we've got to get oxygen to all of the major organs, to every cell, but especially the heart muscle itself, the lungs, the liver. The brain is going to command a lot of oxygen supply, and the kidneys. So the amount of oxygen that we give a patient, the amount of oxygen or the percent that they're breathing in the air that they're breathing, be it air, be it different types of oxygen delivery systems, it's called their FiO2, the fraction of inspired oxygen that they're breathing. And it is the total mixture of all gases, but we want to know what the oxygen is that they're breathing. So the air that you're breathing right now, wherever you're located, anywhere in the world, is at about 21%. It's just a hair lower than that, but it's rounded up to 21%. I want you to understand that there's other things too that Fi is designated. There's a FiN2 for fraction of inspired nitrogen. There's FiCO2 for the fraction of inspired CO2, any of these sorts of things. One of the important things to know is that all the air in the entire world is mixing. So if I didn't show you this slide and you see Mount Everest there in the picture, and I ask you what FiO2 are they breathing when they reach and they're working along climbing the summit of Mount Everest or anywhere, that FiO2 is still going to be 21%. I know that they say it's thin air and they might not be breathing as much oxygen, but it's the same amount of oxygen that you're breathing, be it in San Diego, Columbia, Missouri, St. Louis, Minneapolis, New York, Washington, D.C., anywhere. If you look at this diagram, I just find this so interesting. We've got a weight on us from the atmosphere. So when you're at sea level, it's at its maximum. And as you can see in this picture, the pounds per square inch is going to be about 14.7, almost 15 pounds per square inch, just from the weight of the atmosphere on your body. If you go up to the top of Mount Everest, you can see that the pressure is 4.4 pounds per square inch. And that's what the difference is they don't have the air pressure when they're up there. They've still got the same FiO2, but they don't have the same pounds per square inch. So that's why they use pressurized masks. Unless your body is used to climbing that mountain like the Sherpas, they're going to have a high hematocrit in their blood, meaning that they've got a lot more red blood cells to carry oxygen than you or I do, because they have lived in that low atmospheric pressure environment. Look to see that in the middle of the picture also there's a commercial jet that's flying at about the height of Mount Everest. So in order for people to be able to breathe on a long or any kind of a flight, they pressurize the cabin. They're not adding extra oxygen. They're just pressurizing it so that when your diaphragm contracts, you're pulling air into your lungs so that you're oxygenating your tissues. I just find this really interesting. And remember then that air has mass. If I have people and I'll say, does air weigh anything? Some will say, no, it really doesn't. And I said, if I turned a gigantic fan on you and moved that air, do you think that you'd be feeling the mass or the pressure from the moving gas hitting you, your hair, your skin, maybe if it's in the case of a hurricane, just doing deadly force just with that moving air. So air has mass. And you saw that in that diagram of how much weight it applies to you. So I encourage you, if you've got any weights around, lift 15 pounds and see what that feels like. And know that that's hitting every inch of your body, every second, every moment of the day. As we said, there's also other FIs. And one that I didn't mention was the FiHO2, which is the fraction of inspired water that is really, depending on where you live, at about 0.5%, as opposed to that 21% with oxygen. And that small amount of inspired water is enough to create havoc in the weather patterns the devastating atmosphere can do when heat from the sun is applied to that small FiH2O. You can see these hurricanes here forming in the Atlantic Ocean and in the Gulf. So let's talk about some common modes of oxygen delivery. There's the nasal cannula, and that is what's called an open system, meaning that you can entrain or breathe room air using a nasal cannula. If we see, as in this picture, at about 3 liters per minute, we're at an FiO2 of maybe around 30%. But there's certain emergencies or certain cases where we're going to need more oxygen than FiO2 of 30%. And a simple face mask, which you'll see in the next picture, is delivering a FiO2. Again, it's an open system. There's some room air leaking into the system. They're not breathing purely the gas that's in the mask. If you're breathing only the gas that's in the mask, that's called a closed system. So here's a simple O2 mask. We want to increase the liters per minute to 6 liters per minute of oxygen flow, and that's going to produce an FiO2 of around 50% or greater. Then there's the bag mask valve, and you're going to be able to give 100% with that. And that's your emergent device to be able to give oxygen and breathe for the patient. You're going to want to really crank the flow rate up to 8 liters per minute. So an endotracheal tube or an LMA that's hooked up in a closed system is going to deliver 100% O2 to the patient. One of the other devices that we can use to deliver oxygen to the patient is an endotracheal tube, but there's some other devices I'm going to show you in just a bit that you should know about. In fact, one of them you should be carrying in your emergency drug kit. So the endotracheal tube will deliver an FiO2 of about 100%. You can see in this setup that you're going to need some devices to be able to get an endotracheal tube into a patient. And I encourage you to take a good sound airway course so that you know how to use these devices. There's the laryngoscope handle and a blade. The Macintosh 4 blade is the most popular in anesthesia for an emergency. There's also a stylet that gives some good strong shape to the endotracheal tube so that it stays in a position that's shaped a lot like a hockey stick, and then a syringe that will inflate the cuff near the bottom of the endotracheal tube to prevent aspirate from going down into the trachea and causing the patient harm. And you'll want to see at least 3 liters per minute, and you'll be able to give 100% oxygen to the patient. The endotracheal tube is considered the gold standard of airway devices. You can see that in the first bottom picture on the left, we're using it to place an endotracheal tube, in other words, into the trachea so that we can visualize the anatomy and put that in. But there's some other devices that have become very sound but don't prevent aspiration. And one of those, the one in the middle, is an LMA or laryngeal mask airway. You're able to absolutely give 100% oxygen with that. And in a less common circumstance, unless you're in the military, and I don't know why they use it because it's a wonderful tube. The one on the right is called a King airway. It seals a little bit against the back of the throat, gets the tongue out of the way, but you're able to deliver 100% oxygen that way. So again, it's pretty rarely used. As we can see, and as we just talked about, the laryngoscope has been around for many, many years. It's gripped in this manner so that you can then lift the tissue and visualize the glottic opening so that you can put the endotracheal tube in. But there's been some devices that have been around for probably at least the last 15 years. Here's a picture of a CMAC. There's also the McGrath laryngoscope, and there's also the GlideScope. With the McGrath and the CMAC, all three of those, they are becoming the standard of care now in place of a regular, if you will, analog laryngoscope. They're really nice. You can see to visualize the vocal cords, all the airway anatomy, the glottic opening, and then you position the tube still in that hockey stick type of configuration so that you can bring it in from the side of the mouth, and there's still a stylet there to be able to intubate the patient. So this has really becoming now pretty much the standard of care. But it's all right to use the analog, the older laryngoscope. Another mask that I didn't talk about earlier, it's there. I want you to be aware of it. You might want to have one to put in your emergency cart, is the non-rebreather O2 mask. It's going to look a lot like the simple face mask, but it's got a bag that inflates. So if you crank your oxygen up to at least 6 liters per minute and allow that bag to flow, put that around the patient, they're going to be breathing right at about 100% oxygen. And as we talked about earlier, the pulmonary route is used for nitrous oxide and then oxygen also. So in order to discuss our second emergency medication, which is albuterol, we're going to need to review the adrenergic receptors real briefly. They're the binding sites found on some tissues or organs that are stimulated by either epinephrine or the neurotransmitter norepinephrine. And there's 3 that I want you to know about. One is the alpha-1, the other is the beta-1, and then the beta-2 receptors. There's a lot more adrenergic receptors besides these 2. So for alpha-1, if it's stimulated, it causes vasoconstriction of the arterioles, which are going to be our main physiological determinant of blood pressure, and the arteries. Beta-1 stimulation increases heart rate. Beta-2 stimulation is going to dilate the bronchi. So that's going to be a really important receptor to leave open and to not block, say with a beta blocker to lower blood pressure. We don't want to block beta-2, and there's no drugs that I know of that are selective for either beta-1 or beta-2. So I would know those 3 types of adrenergic receptors that are important for anesthesia. And here's a summary of each of them. So remember that we need oxygen and that CO2 is produced in the chemical reactions that produce ATP. So we want to keep the bronchi open. We've got to have them open so that we're bringing in oxygen and breathing out CO2. It's essential to have good oxygen, good gas exchange throughout a person's, obviously their entire life, but for their anesthetic case that you're doing for your dental sedations and such. One of the beta-2 agonists that's really important to keep with your drug kit is albuterol. So albuterol is a beta-2, again, agonist. It's going to stimulate the bronchi to open up and make nice big passages for gases to be exchanged. So it relaxes bronchial smooth muscle. One of the other drugs that you can buy over the counter, one of the other inhalers, is Primatene Mist. And you'll hear me talking about this in other lectures that you're going to be taking in your coursework with me. So this is used then for bronchial asthma. It's a racemic mixture. Didn't think you'd ever hear that word again, what with organic chemistry and such. But it's a racemic mixture of epinephrine, and it's available over the counter. You need to have both of these inhalers in your emergency drug kit. And like I said, keep them up to date. So it's important that the person uses these properly. And the time to learn that is now, and to practice it way before you need it in an urgent or an emergent situation. So don't alarm the patient when you're going to administer their inhaler. It'll only make their breathing worse with anxiety and such. So you want the person to slowly blow out all the air they can possibly force out of their lungs, and then go ahead and apply the inhaler to their mouth, which is closed over the inhaler. Then go ahead, after you've got a good seal there, and give about 2, 3, or 4 puffs. Have them breathe it in as far as they can take the biggest breath possible, and hold that breath then for as long as possible, so that the gas from either the Primatene Mist or especially the Albuterol contacts all the bronchial smooth muscle and dilates it and opens it up. They can exhale, maybe take a couple of breaths and do a couple of 2, 3, 4 puffs. Hold it as long as they can and really fill their lungs up with the inhaled albuterol, the mist from that, or the Primatene Mist. So we will go ahead and relieve that bronchial spasm. Here is some doses, but read the package and see what the manufacturer says. Let's talk about our third emergency medications every dentist should know, and that is inhaled spirits of ammonia. Now, I've got to tell you, this is an old remedy. It's something that I have never used as an anesthesia provider, but places, certain state dental acts, their rules and regulations have made it so that you have to have those present. So when I brought my drug kit, or when I brought it to a dental office, if I was traveling, I had those inhalers, but I would never use them. And they're used really to treat syncope. It really doesn't open the airway at all, but it's to wake the patient up so that they'll breathe. So just know that that might be part of your state board dental rule or regulation. So what it is it's a mixture in a glass chamber of not only ammonia, which is very pungent if you've ever smelled it, and I'm sure you have, and alcohol, probably isopropyl alcohol. And it's not a lot of milliliters, it's only 0.3 milliliters. So it's wrapped in a glass ampule. It's wrapped in cloth so you don't get any glass in your hands, but you just snap it and put it by the patient's nose, and hopefully that will wake them up out of syncope or if they're having respiratory issues. But it also is very irritating to the nasal mucosa and to the stomach, and it can produce, because of its action, excess stomach acid. So I have it, but I don't use it. Take it for what it's worth, that you might need to have it, and it might be a tool that you could use, and you should have it if your state requires it in your emergency drug kit. Just to show you how strong stomach acid is on the acid scale, it's very, very low pH. There's other ways that we consider to treat syncope, and I ask you to visit your anesthesia textbooks, medical and dental textbooks on emergencies to see how to treat some of the other things that can happen to a patient, episodes that can produce syncope. We're going to talk about a number of them in your other courses that you've either already viewed or will be taking and then are upcoming on how to treat dental emergencies. So let's build your quick and dirty emergency cheat sheet. This is part of your handouts, and I encourage you, as I said, to not only study them, review them every 6 months, and to just know them cold, but you can see that oxygen on the next page, we've got albuterol, and then we've got on the last page the inhaled spirits of ammonia. So this, we're building your quick and dirty cheat sheet form here. So I ask you to refer to that and become very, very familiar with it. We'll progress on to the next part. Thank you.